I think you saw on the way in that there were some booths for some of our sponsors. I encourage you to break, and after we dismiss today, to go back and take a look at the offerings they have there. We also thank several of the sponsors here that don't have booths, and we're very pleased that they support us every year. I think in front of you, you have our meeting agenda, and we're going to, we want to be respectful of Dr. Rucker's time, and so we're going to kind of hold to that. Okay, we'd like to recognize the folks that are here with us today, that are special guests. We have the NeHII board members. Would they please stand and be recognized? Several of them are here today. Thank you. And we have quite a few members on our councils and committees. Would they stand? And these people all put in an awful lot of time. We hold most of our meetings at 7 a.m. and a lot of them have to do it at 6 a.m. out of state, and we really appreciate the support that we get. We also have several of representatives from the State Department of Health and Human Services. Would they please stand and be recognized? They are intimate partner and everything that we do, so thank you very much for attending. We anticipated having Senator Hickleman here today, but he had a last-minute conflict. Do we have any other state senators or government officials with us today? No? Okay, they don't know what they're missing. And we'd like to recognize the NeHII participants, the organizations that have come on board in the last 24 months. If you're here, would you please stand? And thank you. Very good. So these new facilities have come on board primarily due to the ONC Advanced Interoperability Health IT Services Grant. Ooh, I didn't know if I was going to get that one out. Funding, and so we're very pleased that the support that we've had from the ONC to accomplish that. This slide just shows our NeHII adoption in 2016, and the counties that we're in are in green, correct? And we'll just contrast that with the next slide, which shows you where we are in 2017. And we now have 68% of the state's beds connected, 53% of the critical access hospitals. Before the grant, we had 28 hospitals connected, and with the grant, we now have 52. So thank you, ONC. We really appreciate that. So we are so pleased to have our keynote speaker here today, Dr. Donald Rucker. We are intimately involved with the ONC. Deb is constantly on the phone, and the other NeHII staff members. We'll detail a little later. They've asked her to give several ONC webinars, and she's an active part of several of their committees. So we're pleased that Don took the time to come back here to Nebraska and see us. And I actually promised him a Nebraska State. Don and I met several years ago when he was working at Siemens, and he's the chief medical officer. We were a customer, and we pretty much instantly bonded because we were both emergency physicians. And so we did talk the IT stuff, but we also talked patient stories a lot. So we got to know each other a lot, so I was real pleased that he could be here. Also with us today is Matt Swain, who is senior advisor in the Office of the National Office, and we're pleased to have you, Matt. Matt was also our chauffeur out last night. Unfortunately, they had about a 6 or 7 hour travel delay yesterday, so we couldn't make our dinner last night, and so we stopped at a famous restaurant in Lincoln and had dinner. So that was the Dairy Queen. Okay. So Dr. Rucker serves as the National Coordinator for Health Information Technology. He previously worked as a clinical professor of emergency medicine and biomedical informatics at Ohio State and Premise Health. He started his informatics career at Data Medic Corporation, where he co-developed the world's first Microsoft Windows-based electronic medical record. Wow, isn't that something? Have a long way since then. He served as Chief Medical Officer at Siemens Healthcare USA, led the team that designed the computerized physician order entry workflow, and installed at Cincinnati Children's Hospital. He's on many, many different boards, which we're going to let you read his bio. He's practiced emergency medicine for a variety of organizations, California, Boston, Pennsylvania, and more recently at the Ohio State University Wexner Medical Center. He's a graduate of Harvard College and the University of Pennsylvania School of Medicine, and he holds board certifications in emergency medicine, internal medicine, and clinical informatics. Also holds master's degrees in medical computer science and business administration, both from Stanford. So please join me in welcoming Dr. Don Rucker, from National Coordinator for NeHII. At the conclusion of his speech, we'll have the opportunity to take some questions from the audience. And so if you'll just be thinking of something to pick his brain, we'll be happy to facilitate those questions.
Well, Mike, thank you very much for the wonderful welcome. We did have a little bit of a wild ride through thunderstorms and some other things last night, but it's absolutely great to be here. The work that NeHII has done, that Deb and the group have done, we got to tour Judd, we got to tour CHI Good Sam down the road here. Just extremely impressive, really cutting edge for the country, and I think everybody in this room, because it really is a collective effort, needs to be applauded. So let me applaud everyone for the effort. It's really quite remarkable. So ONC, let me talk a little bit about ONC, and then we can get into the questions. So ONC started probably 2004 under President Bush, and the goal was really to facilitate electronic records, or electronic medical records, health records, and ONC's been at it for a number of years. I think you're aware of the kinds of things that the agency has done. Obviously, probably the most well-known is meaningful use, with all of that, all the commotion that came with that. But a number of other things that obviously the health information exchanges, a big part of that. So as ONC and as Secretary Tom Price, orthopedic surgeon who, former congressman from Georgia who heads Health and Human Services for the administration, really sort of has charged us with the two big things are burden reduction, sort of usability of EMRs would be in one category, and then the other would be interoperability. So on a go-forward basis, those are the two charges from the Secretary. They're, of course, what I think as a country we sort of see. So we have a lot of EMRs, we have a lot of electronic record systems, but I don't think clinicians are, they're certainly not inundating us with, oh, I love my EMR. It's usually some other sentiment, which I'm guessing some people here have heard expressed colorfully. Certainly I have. And so that's a big work to be done. And then the other big work to be done is interoperability. Congress has recognized this as well. So this is not just the administration, it is Congress. Congress has passed two big laws that really are our go forward. Now, obviously, there's still the EMR certification under the HITECH Act. None of that is, at least immediately, in the current congressional discussions around the Affordable Care Act and what will happen there. The two big laws that sort of Congress has passed in the last year or so, one is the macro law, the Medicare fix to the sustainable growth rate that sort of was a congressional gain every year, to sort of change the index by which providers were paid, and that had been a gain for 15 years. And as part of that, the Medicare Meaningful Use was rolled in under MIPS, the Merit-Based Incentive Program in Medicare. So if we look at that pile, we have the MIPS macro and the jargon that everybody refers it to. And what you have there are a number of measures and the congressional sentiment that we pay for value, right? So that there's payment for value. Now that's obviously a very complex task. What is payment for value? What is providing value? So that's out there. ONC does a lot of work with CMS, another agency, obviously a much larger agency within Health and Human Services, on some of the rules, definitions, what EHRs are, how those payments go. There's still the Medicare, the meaningful use for hospitals and for Medicaid that are largely from the prior system, and you see there's a public comment that was released yesterday on trying to lighten some of those regulatory burdens on hospitals that you may have noticed that came out yesterday. So that's one thing that Congress noticed. The other thing that Congress has noticed is in the 21st Century Cures Act. Just out of personal curiosity here, who's heard of the 21st Century Cures Act? Is that everybody? Roughly half of folks. So this is a law that Congress passed that has a lot of things on the reform of the FDA and how the FDA can get medicines out to patients much more rapidly with less sort of bureaucratic and research process. But it also had a number of provisions on for ONC on usability and mostly on interoperability. This reflects what pretty much every congressional and Senate office heard. The vote for the Cures Act was something like 392 in favor in the House, and I believe 94 or so in favor in the Senate. This was last December, and as we know, those are reportable things in healthcare. That type of bipartisan sentiment, it reflects what Congress has heard, and probably the congressional and Senate delegations from Nebraska as well, no doubt, on the records don't talk. I can't get my data, maybe less from Nebraska on that, but certainly nationally, some of the provider usability burdens. And so that has left, that law charges ONC with really three, and there are a number of other things. There's no such thing as a simple law, as far as I can tell. And I think that stopped with the Ten Commandments. But it certainly never, nothing in Washington and certainly our lifetimes has fit that. But if you strip it away, basically, along with some reporting on EHRs, ONC and we collectively, through the processes we're going to talk about, have to come up with definitions of interoperability. So what does that mean in terms of operational language? We have to come up with a definition of information blocking. There's a lot of discussion about information blocking. I think, again, Nebraska does not strike me as a place where that was the issue, but in a number of other parts of the country, which shall go unnamed for the moment, that's a real issue. Congress put $1 million a day fine on information blocking on the vendor side, and then some somewhat less specified fines on the provider side. So we have to come up with the definitions of information blocking, of interoperability, as I mentioned, and then open APIs, of which there are some definitions. So the open application programming interfaces, so that a software developer can hook up through, internet address with lots of security around all of these things to, let's say, a provider's EMR or potentially a sandbox of a developer or of an EMR developer, and use function calls in a straightforward way to write code that then takes that information with the appropriate security and uses that. We use those kinds of things in the rest of our lives daily, every day, right? So anybody who has seen a map on their Android or iPhone device, there's a high likelihood you're using the open API of Google Maps, right? Now that doesn't obviously have privacy information in it, but that is the spirit that Congress was getting at, and it defined the open APIs as usable without special effort. Whenever there's special language, of course, this is, lawyers and everybody, there's going to be a lot of commotion about what an open API is, I think is safe to say, but that's what ONC is charged with doing. That's obviously a complex task. I think this audience, more than any audience, knows the complexity of the types of information that are exchanged. We had a wonderful demo on prescription drug monitoring and the NeHII functionality this morning. And there are a lot of complex workflows from a clinical point of view that we got to see there. You know, a lot of stuff that is, for those of us who are clinicians, reflect on, okay, I have this type of patient, how would I get that? What information would I need? So to sort of maintain a little bit of sanity on this process, we're trying to put this work into 3 big use cases. Let me throw those out to see what you think and for you to react. The first use case is the mandate, really, that patients have direct access to their electronic health information, right? So that they can point to an app, maybe not yet built. I mean, there are all kinds of small companies in this space. There's rumor of some of the big tech giants being involved in this. You can pick up any, tech sort of newsletter or e-blog and get, read about the rumors in great detail. There's rumors on basically each of the sort of the tech giants doing that, but that you could point the app and get your information on your device and then do with it as you please, for better or for worse. The part of that, I think, is the compare and contrast is that does not mean go to 5 portals where you may have seen a provider and try to log on. Now, I think that's sort of where we were a little bit earlier in just the world of devices and everything has evolved. That's one use case. The second use case is institutional accountability. Most medical care in the United States is still purchased not by individual consumers, as much as all of our co-pays have been rising every year, but is purchased by large entities, large corporations on our behalf. And how can they look at provider records in a sort of volume type of basis, again with all kinds of contractual security and privacy restrictions, but that's already in HIPAA under payment type of things, and look at that data. So rather than having to go through a cumbersome process to get each individual record, they can do more of a overall query and have institutions be accountable. It is critical as we look at the spend in healthcare. In a lot of markets in the United States, the concentration of providers is such that those markets simply do not have competitive marketplaces from a purchaser point of view. There's just isn't there. So this is our opportunity as a country. This is part of what Congress is looking for with the Cures Act. The third use case is how do we actually define an open API, right? So for those of you who are in the programming world, right, what does that function call look like? What data is exposed, right? What is an open API? So that's our third use case. And again, just point out, one part there is what does it look like at the vendor level? And then what does it look like when a provider has all their data in it? The law requires access without extra effort, right? What does that mean? So those are the 3 use cases. There are a couple of specific things. Obviously, that's a legislative rulemaking process there. I want to highlight a couple of specific things. I know SHEIC, the sort of the consortium of HIEs, was involved in our Cures mandated public discussion on July 24th on trusted frameworks. So, what are the conditions for networks to communicate with each other? Is that part of it? That comment period is open till, I believe, August 24th. We have a technical interoperability day, more geared towards the vendors on August 15th and 16th, where we're really digging into some of the details. As folks know, there's still immense controversy on vocabularies and standardization, and so trying to get, move the ball forward a little bit there. The broader Cures rulemaking will be coming out, I believe, in the first iteration of that for public comment will be coming out in the fall, I believe is the timelines there. You'll see that on the healthit.gov site. So those are some of the specific things that we're doing. That's what Congress, these agencies do what Congress says, right? It's not like we get up in the morning and decide, what to do today. But sometimes when you're on the outside, it seems like that's what happened. But so we're working as directed by Congress on the Cures Act and NIPSMAC, and go from there. With that, I think we'll open up to questions, comments, thoughts. You want to?
We have some questions that were submitted previously, but we'll take live questions from the audience.
Marty Fay, Auburn, Nebraska. Is the open API technology going to be mature enough to be included in the 2015 edition of the Meaningful Use Certified 2015 Certified Edition, so that we can all use it starting January 1?
There is some language in there on that, and I believe it's specified. And again, I am new at this position, so I do not actually know every one of these things, and we can get back to you on the details. My understanding of it is that the technology right now is relatively up to the vendor in the first blush. We're doing a lot of work around the fire standard. We're obviously working with HL7 to have mature things. I think our rub on ONC's work is rushing under-specified standards out before their time. When I was in the vendor side, that was sort of a consistent concern and theme. We're working on some of the fire things, both on sort of what we might call a front end and then a back end type of services. We will be extremely mindful of the maturity of what these things are in terms of the specifications that we put out there, right? Because I think, we get asked a lot of times the questions. I mean, even yesterday, somebody said, if you would just exactly specify, the meaning of every term in healthcare, starting with what an inpatient is, then we could solve our problem. I said, well, reflect on the 2 midnight rule and think about, how one would go about that, right? The biologic complexity, I mean, the brutal reality, as much as when we look at standards, we have to understand each of us has different DNA, right? That's why we're all, somewhat different. And so there's just biologic complexity to beat the band. That's even without all the complexity we put on ourselves in 60 years or 50 years since the start of Medicare, of various regulations and policy. So we're going to be mindful of that. I think the one good news there is that some of the transmission standards are getting much more elegant. So there's something called JSON, JSON, and these are sort of in a class of transmission standards called RESTful standards. So there's some interesting things out there, right? Because the whole high-tech industry sort of has, a version of the same problem. I'm building my app, I'm trying to get it to be new, competitive, better than the next person's app. And so we are making, I think, some fundamental, the transmissions are more brittle and allow more variability in what data, is transmitted. So I think there's some things out there, but I take your point because I think it's on target. Any other questions?
Let's just ask this one. What support will be available for state and regional HIEs from the ONC now that the ONC Advanced Interoperable HIT Services grant funding is ended?
Yeah. So, as folks may or may not know, our budget was cut from $60 million to $38 million in this sort of the next sort of cycle. That just, that sort of that looks to be baked into the congressional preliminary budgets. There's a whole I'm learning the whole congressional budgeting process and all the ins and outs of that. That's probably enough for a novella. So. At the moment, there are not explicit, the things that Congress has asked the agency to focus on are some of the policy and some of the standards work. That's sort of the target areas. We're going to try to do what we can there. I think in meeting with Sheik, including Deb was there, we identified some very interesting things that HIEs are in a very good position to do on some of the behavioral health issues and some of the things that are very local for, very challenging populations. And so I know I'm personally trying to work within Health and Human Services, which has many agencies that fund taking care of these people, and see if we can think from a HHS point of view a lot more creatively about the potential role for HIEs. So, this is just, very early work, and obviously the HIEs and chief need to, pursue that with their, with their congressional representatives. But I think there may be some interesting opportunities to provide even more value, and provide value, because I think sometimes there's honestly a challenge of what are the boundaries of an HIE. I think we saw the maps, and but some of these, a lot of the things that cross behavioral health are incredibly local, and of course we're seeing some of that with the PDMP stuff. So I think there are going to be some interesting opportunities as that all morphs, I believe. That's Don Rucker's personal opinion, but as somebody who sat in ERs and seen patient after patient, as I'm sure Mike has, and Jim and folks, you see the patients, it's really pretty, there are a lot of people who are not serving, who just have bad luck with their genes and the environment that can probably do a better job at.
University of Nebraska. Speaking as a physician and as an informatics specialist working with electronic health records for a long time, I'd really like to compliment ONC on the Meaningful Use program and the dramatic changes it's created within the American healthcare scene. And I thank you.
Of course, I had nothing to do with it, so just by way of disclaimer. But we'll pass it on to my colleagues who did. And Matt's smiling there. Matt's been here for 7 years, so he can.
Speaking to the issue of interoperability, we're working on implementing a lot of our electronic health record data in our research data warehouses and the like, implementing the learning health system.
Yes.
And some of the issues that we have run into relate to the problems that the terminologies which are specified by ONC, especially for medications, secondarily for lab tests and so forth. Some of the terminologies do not support all of the technical features that allow us to maintain databases, many of which go back 10, 15 years, and actually resurrect that data which is coded with codes that are now no longer active. NLM and the FDA, for example, do not support very good historical mechanisms for terminology management. And I would just like to put a bug in your ear that I think that ONC needs to give some attention to the operating characteristics of these terminologies and make sure that the organizations who are responsible for them are publishing tools that are needed in order to use them, because we're going to have more and more history in our electronic health records this way.
Yeah, you're right. It's been very, very complex, right? All of these systems, right, have had extraordinary legacy. You can just tell me when it's time to stop. I don't need the silence. You just kick me or something. This sort of the legacy of things, right? Because it was all sort of homegrown on some level with terminologies, and there's been a lot of work. And when you look at LINC and RxNorm, which you're referring to, I believe, to standardize some of that. Some of these are commercial terminologies, which there's a challenge, right, when federal agencies require commercial terminologies, right? So everybody is paid either directly or indirectly fees for example, CPT, right? So there are challenges around that, and this is a challenge. If you're doing, for example, CPOE, every orderable, every charge master, sort of started seemingly in the dawn of time somewhere where these things, somebody somehow came up with codes. So how do you put this stuff together? And it's you know, if you're building data warehouses for research, obviously that's one of the big challenges. I think the folks who are working the standards are pretty aware of it. It's some of this is, I think, you know, some of the benefits are going to be on a more go-forward basis. But even the standards that are out there now, we hear concerns about optionality, not enough optionality. It's a very delicate balancing act. Part of it is, if you look at things like meds or labs, I mean, there's constant evolution. There are new medicines every day. New diagnostic tests are literally coming out, depending on how you can all the gene packaging and sequencing things and algorithms sitting on top of those. They're coming out on a constant basis. They're being repackaged. So that's some of the challenge, but it's certainly there. That doesn't give you an immediate answer, I understand that, but I mean, it's more of a reflection on the challenge that we have. Any other questions?
If you have a question, would you please come up to the microphone? We have a very active privacy and security committee, so I suspect this came from one of them. Please describe your vision for integrating NeHII privacy requirements within other federal agencies pursuant to the elimination of the Chief Privacy Officer position at ONC.
Yeah. Well, we're sort of sorting out what there's a line item in, I believe, high tech on the Chief Privacy Officer in ONC. So we're actually sorting out exactly what that is. As folks know, we have in the past and continue to share a number of the privacy and security functionality with the Office of Civil Rights, aka HIPAA. But I think you can absolutely rest assured that the standards we put out and the things that we're pushing have a deep and constant concern for every form of security and privacy. This is an area of extreme work in the computer industry as we look at things like open APIs. They're not really open; they're actually open with, you know, very specific security. You know, so it's the difference between having a door that's just open and having a door where you need a very specific key, right? The things we're talking about, the open API doors, there will be keys and all types of privacy things. Again, a lot of this is a cat and mouse game with the people who are bad actors and who want to hack in and destroy stuff, you know, which is sort of a global phenomena. And but we're very mindful of that and see a strong role. And I think privacy and security is part of the base package.
That help you out, Jim? Okay. Any questions from the audience? Yes.
I'm the state epidemiologist, and I'm representing the public health benefits that we've been deriving from both the community use requirement and from the whole HIE movement. I wanted to publicly make you aware of whether that role Jim Daniel has been doing in your staff and helping us in the public health community to see that we're deriving maximum benefit from that. We've seen this as dramatic moving target. You know, we're getting things like electronic lab reports reporting diseases, vaccines reported, and ED data reported public health. But it's such a moving target. And one of the things we've seen lately is laboratories moving away from concentration in the lab to point of care testing. And I'm just kind of curious when you're talking about the open API, whether you see in movement there where, you know, the providers of this are going to be required to figure out a way to extract important disease data out of that point of care testing is public health. I don't know if that's within the overarching framework of the open API discussion.
I don't think it directly is. I think the open API discussion is more a discussion about access to the electronic health record rather than feeder systems into electronic health records, which is the classic way that people look at point of care. And obviously there's a whole bunch of CLIA. It's a very dense regulatory space. I think there's going to technically, so I worked for a number of years for Siemens, which is at the time, and I believe still is the third largest lab vendor in the world after buying all kinds of stuff. And so I think so I have some experience in that area, and I think what you're going to find is there's going to be a constant balance between what you do in the periphery versus what you do in more of a central lab. I mean, central labs are getting highly automated. Point-of-care testing is getting pretty fantastic. I believe most people who are implementing point-of-care in clinical settings are doing it with ways to capture that data. That's just my personal experience on that. I think there's also some regulatory language around that, but I'm not familiar with the details. Part of it, from a public health point of view, obviously some of these institutional accountability things, the ability, for example, for a public health agency to do a broader query is one of the use cases we're thinking about. So we definitely have both public health and population health. You know, that's a subtle distinction, maybe not a distinction, but have at least both those use cases in mind. Thank you.
Any other questions?
This one has several parts to it. So Nebraska was the first state to integrate the PDMP into the NeHII. Do you see this trend continuing to expand in other states, and will the federal government encourage the integration of PDMP into NeHII systems? Do you see other federal agencies becoming more involved in NeHII support efforts? And do you think other states will pursue the reporting of all filled prescriptions as Nebraska has to deliver med reconciliation tools to prescribers and dispensers?
Okay. Any other questions?
I'm not done yet.
So let me tease out those things. And again, now so there are not active legislative, there's not that I'm aware of a bill in Congress or a bill that's passed or a bill on the president's desk to do any of those things, right? So we're in the realm of speculation on these things. I think there's an overarching pressure to integrate PDMP information into clinician workflows. That's, I believe, what the true pressure is. Various states are doing it in various ways. There are various standards are doing it. Various vendors are integrating that in various ways. Where and how that ultimately is integrated. But obviously, the closer that is to when clinicians are ordering these substances and having a discussion with the patient about their medical issues, right? Hopefully, at the start of the visit, as we saw today, potentially, that's really where it is the best. If I take care of a patient, as I'm sure we both have many times, and at the very end, you think you got everything wrapped up, and at the very end, oh, I need some pain medicine. I think I've heard that many a time. And then it's, well, I forget the name of it, but the one with the P really works well. There's just 5 or 10 more minutes of visit, as you think the visit is finishing. So, right, somebody's sitting in the waiting room waiting. What is that stupid doctor doing? They don't seem to be doing anything. We're having a discussion about this. So, how that integration comes, I don't know. Obviously, the tighter the integration, I think, like all things electronic, it will become tighter. The next question? Just give me the word or two here.
The other federal agencies becoming more involved.
Yes. So there's a lot of work in the Trump administration on opiates. This is, I think, bipartisan. There's a lot of interest on that. There are literally multiple meetings a day trying to sort out, obviously, what we as a country can do there. It's not easy. This is not a news fact. It's not easy to try to figure out what we can do there. There's a lot of effort. I do not know. I'm in our group, ONC, is trying to push some of the more electronic approaches to this. SAMHSA, the mental health agency within HHS. There's just a lot of interest in doing this. So I think you're seeing things. There's a big bolus of funding, probably worth Sheik trying to lobby to get some of that, frankly. There's a big pile of money that I believe is working its way through Congress in a somewhat, not yet specified way. So this would be a great time to talk with people and see about that. What was the last part?
The last part was, do you think other states will pursue the reporting of all filled prescriptions that Nebraska has?
I think so. We were talking earlier today at Good Sam about the extraordinary work of MedRec, so the medication reconciliation, which has been a requirement, and I think many of us on the clinical side realize that that is done imperfectly at best. That would be an understatement. I'm suspicious. Right, because
Big difference between prescribed and filled, right?
yes, I mean, the reality is you're going into the brain of somebody, trying to dissect their behavior. When you look at MedRec, we don't have truth serum. What meds are you on? That also refreshes your memory. There's no pill. Take this pill, give me your complete and accurate list of medications. So we don't have that. So it is a game where we're taking probabilities and working with the patient's family, trying to do that. So any kind of tools that get better, and of course the need for that becomes larger, because one of the things that sort of is in the whole background of this is our medicines are becoming vastly more powerful over the years. When I started as a med student, we essentially had almost nothing for high blood pressure. We had nothing for ulcers. We had very limited antibiotics. Statins were a decade and a half away. All the anti-inflammatory meds, ACE, ARBs, those classes of medicines, Adrene, the very first beta blockers were just about to come out. So, we have way more active medicines, right? For diabetes, essentially, we have almost 1 or 2 oral agents that work quite poorly, very brittle, highly allergenic insulins. I mean, the medicines we have and what people are on is just vastly richer. So I think there's going to be an ongoing pressure to get med data in everywhere.
Thank you.
Well, thank you very much. I appreciate the invitation on behalf of ONC. Matt Swain, my colleague, and I certainly have enjoyed our unfortunately brief stay here. And it's donald.rucker at hhs.gov. So if you guys have some thoughts on or something, I wish I should have said that, or why are you doing this? I can't guarantee you an answer exactly, because I may not have an answer, but love to hear from folks, and we'll go from there. Thank you.
Just on behalf of NeHII and the state of Nebraska, we're just so honored that you came to see us today. Dr. Rucker has to absolutely be back in Washington, so he's going to have to leave in about 10 minutes. But we asked him if he could stay just a little bit so he could hear the activities that we've been able to accomplish just within the last year. Deb gave me a series of talking points, and the first one I'm just going to read because I think this relates to the activities that she's been involved in and NeHII's been involved in with the ONC. NeHII was honored to be given a great deal of national recognition this past year with a number of national webinar opportunities sponsored by the ONC and our work being used by the ONC as a tool to other leading HIEs in the country. For example, the ONC asked NeHII to present on the relationship building we have accomplished over the years with our state partners at the Division of Public Health and Medicaid via a national webinar last November. We were also asked to tell the NeHII story of our journey to sustainability through a national webinar hosted by ONC this past July. In April, NeHII's worksheet to capture data elements in ADT messages was also used by the ONC as an example for other states in populating ADT messages, and this was at the ONC-sponsored boot camp. And finally, NeHII sponsored 2 additional town hall webinars to a national audience, which featured our 2016 annual meeting and the 2016 annual report with good attendance on both. So we have a long-standing tradition of sharing our successes so that others can learn what might work well for them as well. So again, thank you for integrating us into your activities. We started reporting the notable activities several years ago, and we could take one slide with big type
Now we're up to 3 slides with type that you probably can't even see. As we just tell you the several things that we've done. I think I'll just highlight a couple of them. We really had a banner year in getting some contracts done. Our Doctor First Master Services and PDMP system requirements were finalized. We also have got a 5-year Master Services agreement with Optum for HID 2.0. The 9010 high-tech funding request for an additional round of hospital and provider adoption and added functionalities was submitted on time and received grants from that. We passed Senator Kuhn's Bill 223 that outlined PDMP enhancements. We had an issue where nurses could not access the PDMP. It was interpreted as, the law was interpreted as being providers only, and so that pretty much limited the amount of providers accessing it, so we're actually very happy to get that done. We attended quarterly meetings with our state partners, and a future added value services work group was formed and developed a new pricing model, which we'll talk about a little later. And in October last year, we passed a 1.2 million mark for number of clicks per month, which was pretty interesting. And in quarter 3 of 2016, we had 953 new users. And I think we also reported about the national webinars that we did. We completed an Office of Civil Rights desk audit. We were honored to be one of the first ones to be able to do that, and we completed that on time. We're very, very proud that we did that. We had a record year for new adoptions, 26 new users last year. We got the PDMP rolled out, and our new pricing model announced in 2017 removed all fees for licensed healthcare professionals to access data in the HIE. That was huge. And I think the next one is also just very complimentary of Kevin and the PDMP group. 100% of Nebraska community pharmacies were reporting to or completed waivers for the PDMP within 3 months. That's just kind of unheard of. We had new board members. We attended the ONC boot camp, and we welcomed new employees, Kathy Johnson-Simmons and Amy Plants-Novich. And we sponsored, we got out and were seen in several different venues this year. We announced our United Healthcare and WellCare as new payer participants in 2017. I've had nice conversations with both those organizations today, and thank you very much. Appreciate that. We have a new privacy officer in 2017. We sent 5-member delegation to the Strategic Planning Review in Lansing, Michigan. The one bullet that's kind of important there is we developed and released statewide consumer awareness campaign, and I think when that committee reports, you'll see that. We have actually electronic billboards still up today in Kearney, and several of you got to see that. We also approved a quality reporting services strategy, which was developed by our consultant Jamie Bland, and we're getting that off the ground. Record number of new users. Deb Bass was reelected as a board member on the SHEET board, and staff members from 35 hospitals received the NeHII readmission report, and as everybody knows, that's been a really, really well accepted thing. And I told you about the number of beds and hospitals that we have, and we're really proud of the next to last. My last one I couldn't call a bullet point. So a dot point, a record number of HL7 implementations. We had 7 go-lives in 1 week. So that was a lot of hard work, and we really thank the NeHII team for that. And we completed our platform migration to the HIE 2.0 in July of 2017. So I'd like a round of applause for the whole of NeHII. NeHII didn't invent the term lean, but we certainly embody it, and the people that work on our team are just phenomenal. I'd like to give you just one testimonial. This came from a community health education senior at the Nebraska Department of Health and Human Services. We love NeHII. It's already helped us on so many cases. We've been able to find PCP info, charting errors on the discharge summary, updated phone and address info on the patients. It's already making a huge difference in our follow-up. The system works great as well. It's user-friendly and reliable. So, Again, Dr. Rucker, thank you so much for coming here, and I hope you got to see how involved we are and how much we believe in this effort, and we appreciate your support of us. So, again, thank you. I'll meet you outside in 1 minute. Our next topic is the benefits of an integrated community, and Gary Cochran and the team from Auburn, Nebraska will be presenting that, and we have them come up.
Good afternoon. I'm Gary Cochran from University of Nebraska Medical Center. I've been a faculty member there in the College of Pharmacy for a long time. And I've had a chance to, most of my work is spent doing medication safety research across the state and the region. And so I want to start with introducing this panel here, but I want to start by thanking them for all of their hard work. This was not an easy project. And they were taking a little bit of a leap of faith when we started this. There were no clear endpoints. This was something where we learned from each other as we went along. I want to start with Marty Faddick down at the end. For those of you, I should say that when I started the introductions, I started going through and grabbing some bio information from each of them. And by the time I got to the third page of text, I decided this wasn't going to work. So I'm going to make this very, very brief. Marty is for those of you that know him, is the CEO of NeHII County Hospital in Auburn, Nebraska. And I've got a couple of different sheets here that I need to organize. I met Marty over 10 years ago when we first started working on medication error studies, and his leadership and willingness to try some different things and support a number of these projects is something that I will always be in your debt, and I appreciate your participation. Moved down here to Kathy McNaughton. Kathy McNaughton is the Chief Information Officer at NeHII County Hospital. And she was a resource that, for those of you that are thinking about or interested in this integrated community concept, you're going to have to find someone like her in your communities. She is not only an expert in the technology at the hospital, but was very familiar with the other organizations that participated as well, and helped us work with NeHII and their IT group to make a lot of these things work. Dr. Michael Zaruba, thank you for coming. He was just able to get here. And so Dr. Zaruba is a family medicine physician at the Auburn Family Health Center in Auburn, and he also provides care in the hospital. Dr. Zaruba wore a couple of different hats. Without his leadership, we wouldn't have had the clinic participate, but he also provided the clinical use cases that we needed to try and see whether we could support use of the health information exchange. Jeff Harvey is the administrator at the Evangelical Lutheran Good Samaritan Society in Auburn, Nebraska. We're thrilled to include the long-term care facilities. It's the group that generally doesn't get invited to the table when it comes to some of the funding and the opportunities, but they're a key component in the integrated community. I'll define that in just a second. And then Amanda Harrowfield is an RN and the Director of Nursing at the Good Sam Society in Auburn. And she was instrumental in bringing about, again, all those clinical use cases that we tried to implement. So again, without all of their hard work, this project, we wouldn't have been able to complete it. So I've got about 30 minutes, or we have about 30 minutes to visit with you. And the way I wanted to break this up, I'm just going to take a couple of minutes to introduce what this integrated community concept is. And then we'll have some prepared questions for them. But I want to encourage you to come forward. If you have any questions about any of these facilities, what they did, why they did it, what challenges and so on they had to overcome, please feel free to do so. And then I'll take the last 2 or 3 minutes of the time. We tried to take much of what we learned here As a good academician, we write papers that sometimes I'm suspicious are never read again. So what we wanted to do is create some training modules that we could publish. Most of the modules that are out there about health information exchange are written more from a consumer standpoint and are very brief. So at the end of this project, we have about 73 minutes of videotape broken into smaller sections, and it's available through the NeHII website, and it's hosted on the UMC website, but you get to it by going to UMC, and I'll show you that at the very end. So the integrated community. We define that not based on geography, even though when it comes to the geography, I think you all are about 100 yards apart. But it was based on patient referral patterns. So one of the things with health information exchange, when you go to use it, if you go and look up inpatient information that's not there, it doesn't take very long before you wouldn't include that in your everyday workflow. So by creating an integrated community, one of the first things that we did, we had the hospital as both a data provider and able to receive data. The clinic was willing to become a data provider as well. And then the long-term care facility was also included, not as a data provider, but they had the ability to send, all of them had the ability to send and receive direct documents, and the ability to use the health information exchange, the query-based HIE, to get information. So with that kind of infrastructure, the first thing that we did was we sat down individually at all their facilities and started doing a needs assessment. So we asked for those use cases that would improve clinical care, patient safety, or efficiency in their organizations. Then we started meeting as a group for the rest of the grant period to see what could be supported between the two organizations, the sending and receiving organizations. And we started to implement those into the workflow after we were able to test and demonstrate the technologies. So that was the idea of the project. And so with that, I've broken these questions that I prepared into kind of two different groups. One is finding value in HIE. When it comes to spending the money, that's one of the first hurdles that you need to get through. And so that's where I wanted to start the discussion with you folks here. So the first one I have would be addressed to Marty. You were one of the first critical access hospitals in Nebraska to decide to make your data available to NeHII. What made you think it was a worthwhile investment? And do you think the results justify that investment?
Well, thank you, and thank you for including us in this big endeavor here. I think we all learned a lot, and I think we created some plans that are very we can replicate in communities throughout the state if people have the desire. I first became interested in the HIE back when we first installed our electronic health record, which was in 2004. It was great. It was wonderful. We had all this data that we had on every patient, but it was very limited as well because we couldn't share it with anyone. And I thought, why can't we share this data with someone? And NeHII was in its infant stage at that time. And so I have to be honest, I was a skeptic. I looked at every way possible to do HIE without NeHII. I contacted people in many different states, and I talked to different IT professionals, and it didn't take me very long to realize that anything I did other than join up with NeHII and use their expertise would just be adding to the problem of HIEs not talking with each other and us still not sharing data. So I came on board with NeHII early on and immediately saw the value. Now, my colleagues would ask me, what value do you see right now? I said, right now, not a lot. Remember, this was early on. But I said, the more of us that join, the more value there's going to be in the future. Sometimes you have to look down the road a mile or two to see where the good things are lying, and they're not right in front of your face. And that's the way it was with NeHII. We got on, became an avid member, and I have to tell you, I have a mantra that I live by that has gotten me in more trouble than anything else I can do, and that is, I have a mantra that goes, with the right to complain comes a responsibility to participate. I do my fair share of complaining. Therefore, I have to do my fair share of participating. And so we are always anxious to join in with something like this, see if we can't make it better. And I have seen so much growth in NeHII since we joined, in spite of us, not because of us. And are the results worth the investment? Absolutely. And I think everybody out here would agree when we went ahead and moved on into the integrated community.
So this asks basically to each of the different facilities. Amanda, Dr. Zerba, Kathy, anybody that wants to chime in, could you guys provide one or two of the use cases that are providing value now in each of your organizations? What are some of the low-hanging fruit, some of the things that you can start doing early on, do you think? Whoever wants to start.
So the value as a provider right now to my clinic and my partners is probably seen in med reconciliation. Again, it's not perfect. It's not completely automated yet, but I will tell you that our charts have probably improved 90% in terms of having accurate med lists. It's pretty rare that I do a pre-op H&P and have to ask the patient now what meds are you on, are these correct? We've changed the workflow process where our nurses essentially med rack every patient and are able to do that. The next step would be to get it to be automated where we can have a single nurse, essentially med racking, ER visit, discharge summary, and I think we can get to that point. So that's probably the biggest benefit I've seen so far. I think the second benefit is probably being able to obtain the information a little quicker. I mean, we all see patients that come into the clinic and your chief complaint from your nurse is follow-up ER. So what's that mean? Where's the ER? What are we, and so now we can obtain that information a lot quicker. There's a lot more low-hanging fruit out there that we need to be accessing, but I think those are the two where our clinic has really benefited.
I would say for the long-term care center, the biggest thing for us is being able to retrieve the information that we need for our residents for wherever they go. If they go to the hospital, they go to the clinic, to get that lab results, the x-ray results there for the follow-up when the doctors come around to do their rounds twice a week, so that we're not having to call the medical records and have them fax us or fax us the results. We can just get them right there, print them out, and have them ready for the doctors. That's what we use it the most for, and then also keeping track of our residents that may go into the hospital in Lincoln, and so that we can look and see, how are their labs, what's all going on with them, and get an idea of how their hospital stay's been before they come back to us, so we kind of know what to expect when they get there.
I'm in IT, so I don't work the floor, but what I've seen within the interoperability that we've done with this community project is that I think it opened up the doors for communication between the facilities, and I saw time and time again, especially with use cases of the long-term care facility saying, hey, this is what our process is when we get your paperwork, and we're saying, well, this is what our process is, and the clinic may say, well, we don't get anything, or this is what we need. And in the middle of that, we found that half of the paperwork that we were sending back and forth was really just thrown in the trash and never looked at. And we found that the CCD could take or replace a lot of the paperwork that was going back and forth, and that could be done electronically in a lot of cases. And I think that's what I saw was the best benefit, is opening up those doors of communication where even though we are literally in walking distance to each other, that had not been done completely in the setting that we had and had the ability to work with.
Thank you, and that actually kind of led into and you answered the next question, was when I've been involved with communities or organizations that are adopting NeHII, many times they look within their own walls, and the question was, do you see a benefit in getting everybody in your community that are sharing patients around one table? And I think you just addressed that. So Marty, Jeff, Dr. Zaruba, how how might changes in payments, so say value-based payments, for example, impact the importance of being able to share information through NeHII?
Well, I think, we all, as physicians, we all know we're being profiled on everything we do, and we're in 4 quadrants. Are you low quality, low cost, high quality, high cost, those kind of quadrants. And I think with being able to access information, if I have a patient come in and says, well, I had this test done in Lincoln, but I don't really know what it showed, or I don't really know exactly what the test was. They rubbed something on my leg, and maybe it was a dot, or maybe it wasn't. I need to find those test results, or else I'm going to have to repeat them. There you go. You save money, you use the healthcare dollar efficiently. And so I think anytime you can share information and not repeat tests, you're gonna improve the quality of healthcare, and we're gonna become much more economical. And that's a place, not to get off the topic of the question, but that's a place where we need to go. We really need to, there's low-hanging fruit out there with radiological procedures and x-rays and stuff, and the more people in the state we can get participating, especially our radiology groups, it's going to make a big difference in patient care.
Yeah, with the long-term care industry definitely facing a lot of challenges right now with funding reductions, some places declining census population. So definitely a challenge though is that we don't want to compromise the quality care for our residents that they receive and deserve. So I think our funding system probably will be moving to a value quality-based payment system, and we need to utilize technology like this to be more efficient, because we're having to do more with less. And I think if we can get information faster, act faster, it only will provide better outcomes for our residents.
I would just add one thing, and then I was just involved in a think tank in Raleigh, North Carolina, on this topic of connectedness and value. And one of the participants there said something that I thought was a profound statement. They said, value-based care must have complete data, which requires connectedness. And they said there is no value-based care without connected care. So I think as we're moving in that direction, we really need to make sure that we're connected, and I think the ONC has that as a top priority as well, so I think we can see where the federal government is headed with that as well.
Any questions from the audience about the value side of things? Again, there are a number of hurdles when it comes to complete implementation in an organization that need to be overcome, but that's one of the first ones that people face. You've got expertise from 3 different organization types here. Any questions about finding value?
Officer Fran, again, I'm the state epidemiologist at HHS. Really love this discussion on how you're exploiting this NeHII to communicate patient information. We all know patients are transitioning as quickly as possible out of more expensive care environments to maybe less expensive care where they can still get well but not cost as much to the system. And so there's going to be a lot of this transition of care. So when you mentioned CCD, my ears lit up. We can find a problem in public health where people have conditions where it's important for the next care provider down the road to know about it, and some of that information maybe doesn't seem, at least to my eye, currently available on the CCD. Have you guys had any experience with things like a student get the CL, MRSA, tuberculosis, things of pushing they have in one environment, and they get to the next environment, and they say, well, I didn't know they had that, and how come somebody didn't communicate that with me? I hear movements of people create a new form, paper form, fill out, just like what you said, people hate them and don't fill them out or throw them away when they get there or don't read them when they get there. But has that been an issue at all in terms of community safety between nursing home and hospital and that kind of thing?
I would say this, that I don't think it's been an issue so far, but it obviously is a challenge. And since it is a challenge, we are set to embark on a new pilot project with NeHII to create a gateway with public health to dump our reportable labs into NeHII through a pipeline. They won't reside in NeHII, they'll just pass through the NeHII connection into public health and dump straight into you guys, so that reporting will become less burdensome for everyone and should be more complete.
That would be great. I guess what I'm looking for more though is that discussion between, say, a nursing home's got a patient, the person's got C. diff, and they're getting moved into a hospital, and the hospital isn't aware of what's going on in the nursing home. I don't know how all that information is captured on CCD.
We found that the CCD did not incorporate everything that we needed. So what they've done is we don't rely completely on the CCD at this time because of some technical difficulties that we're still working through, especially with our EHR. So we haven't had that issue, but I do see that the CCD needs to be expanded more and include more information in some areas and maybe less in others. I think as more people use the CCDs and see the value in it, the better the information will get. Right now, what I see the issue with the CCD is we do have the standards that have to be on it, and then it's up to the EHRs and or facilities on what else they want to add to it. So they do have the standard, but there does need to be more information on it, and I see that coming up as more people use it.
Yeah, and from a physician standpoint, even though there's minimum standards for a CCD, really the minimum standards are inadequate. We need as, you know, I don't know where it comes from, but we really need a CCD that is probably more standardized, because every EHR is different on what it's going to include in that. You know, there's the minimum, and then there's all the things you can check and select under different options. And I think we need to probably, as an industry, have a more standardized CCD.
One of the challenges, or one of the use cases that we were working with between the hospital discharging a patient and the long-term care facility accepting that patient is getting that information. If you wait for the CCD for the discharge summary to be done, by the time the CCD gets there, the patient's already been at the long-term care facility. So a lot of the issues were more around timing and the information that would be included in it. And some of the challenges we tried to overcome were, could we create a CCD at the time of discharge before the discharge summary was done? There's enough information in there that they can get a lot of work done at the long-term care facility. But how do you automate that? How do you incorporate that? How do you make sure that the med list that comes from the hospital, it's not the inpatient med list, but it's the reconciled med list for the outpatient? So those were more of some of the issues and challenges we had around CCD. The other thing is you can have many providers in one facility, but sometimes there's one direct email address. How do you coordinate the flow of the CCD and get it to the right provider at the right time? So those were some of the things, the challenges that this team worked an awful lot with. And I'm sure there'll be a 2 and a 3 and more coming. Thank you. The next couple of questions I have is more of creating this integrated community. If you wanted to try and do something like this yourself, the first question I have, Jeff, Dr. Zerba, Marty, for those in the audience who might be thinking of doing this, to share, thinking of partnering with other organizations to share data, what advice would you provide about where to begin? Who needs to be involved to create this kind of a integrated community?
Well, I think from a clinic standpoint, you need to have a physician champion on board to do this. If you don't, I don't think you're going to be successful. I think as you look at participating with another group, you need to also not ask the question, what are they going to do for you? Going back to kind of what Marty was saying at the very beginning, ask what you can do for them, because it's a two-way street. When you open up those lines of communication and you start sharing that data, then a lot of other things can happen, because if nobody's sharing data, then you don't have anything. And I think you got to be willing to, check the ego at the door, about your data. I think sometimes we run into some of this where, I don't want to give my data up because I have all this data, what am I getting back for it? And I think that that's a terrible mentality, and that will doom you in the beginning. And you need to be able to be flexible. You need to be able to work with your workflows. So you have to change your workflows. If you don't change your workflows, that's the number one thing that will take you out of an EHR. You got to figure out how to make the workflow exploit the HIE or the EHR or both. I think when you get that mindset, then I think you can really do some really neat things. So from the standpoint of the clinic, the physician champion, being able to change your workflows and not asking what's it doing for me, but what can I do for it?
Yeah, I echo what Kathy had said earlier. It definitely requires collaboration, and it's easy in your own world to start working in silos, and that has to be checked at the door when you start meeting, and have an open mind. Definitely having key providers is essential. Key players among those providers. And I think one thing is there's lots of data out there, so trying to determine what data is most valuable to you as a provider is critical. I know Gary and his NeHII team were very helpful with that process.
I would like to echo what Dr. Zuba and Jeff both said. I mean, it is vital to have a physician champion. I also think something here that has not been said that I think was very, very important, and that is how critical it is to have a long-term care facility that is interested in doing this. So many of them are not, and when we found a partner that wanted to collaborate with us, I found that very exciting. And when I presented this information to that group, that think tank in North Carolina, they said this is unheard of, that you're sharing data with a long-term care facility outside of your network that you don't own. They said it's just unheard of. But I think another thing that was very, very important, and I would suggest this for anyone, and that is kind of the way Gary got us started. And that was not by talking about abstracts or just this goal of data sharing, but he made us sit down and come up with use cases and what problems, roadblocks, pebbles in your shoe are caused that we can fix with interoperability. And we started working through those, and we come up with when we think, yeah, we can do this if we connect. Now we have a reason to connect. I've always said, if you install technology for technology's sake alone, it's going to fail. But if you're using it as a tool to accomplish another goal, you'll be successful. And that's what we did by defining use cases.
Thank you. I see I'm starting to run out of time, so I'm going to skip a couple. I do want to ask Kathy, real quick, from an electronic health record perspective, what would you say to hospitals or clinics or long-term care facilities that are thinking of becoming data providers, HL7 data providers? What are a couple of things they need to ask either their vendors or NeHII? What are some of the things maybe that they need to think about that maybe weren't obvious?
Well, first they need to learn HL7, but which Connie Pratt taught me very quickly and Leanne. I think what they can do easily is contact their EHR and explain to them what they're getting ready to do and ask them if they have the ability to do it. It's a simple HL7 interface, but the EHR really also needs to be forward thinking and have a mind for the future, because as NeHII grows and morphs into new areas, it needs to grow with it. But contact your EHR, explain to them what you're trying to do, get those versions and all of that information together. And I don't know of any, Optum has always been very open and helpful to get through all of that and teaching everything. But sit down and figure out what goal is and what you're moving forward, and start asking questions and get the information together that the EHR telling them, and every EHR is going to be very helpful in getting that information to you.
Thank you. That's one of the things that we found over and over again. If you have specific use cases that you want to try and integrate, now you can talk about specifics and not generalities. Can they actually support the use cases that you'd like? I am running out of time, and so I'd like to thank first off, I'd like to ask, are there any other questions? And would anybody like to ask any questions about the panelists? About or to the panelists? All right. Please join me in thanking them for real quick, while they're taking a seat, it's always fun trying to test technology in a technology meeting. Let's see if this works. So the modules that I was referring to are now live on the NeHII main site. If you go to the Health Information Exchange Guide on the front page, you'll be brought to a site where you'll see this page. You click on it, and it will go ahead and launch this Health Information Exchange modules. And what we tried to do is break down the modules and the components. One is just going to be a background of the Health Information Exchange. Two, we'll talk about the technology, so if you're not familiar with Direct and HL7 query-based models, that's in there. We've talked about how in the second modules, how to do the needs assessment, the use case identification process, and then some strategies to implement into workflow. So just the first 10 seconds or so. Welcome to the Health Information Exchange Guidebook, a series of modules designed. So you can go ahead and work through these. There's about 75 minutes of content in there. Unfortunately, I wanted James Earl Jones or someone else, but you have to listen to me. If there's any feedback, please share that with the NeHII team and we can make adjustments. Thank you very much for
Thank you, everyone from that team. And all we have to do now is figure out how to clone these guys and gals, and we'll be in great shape. Now Dr. Rucker's left the room, I just want to tell you, he said he's only been in HHS a short time, but coming out with him last night from Omaha, he has regular one-on-one meetings with almost all the cabinet secretaries and all of the key senators and representatives that you hear about on World News Tonight every night. So he is everything that he's learned from us here in Nebraska and the suggestions and the bugs that many of you put in his ear, you can guarantee we're going to get some traction out of that visit. So again, just another good reason to have him here. Well, you've heard a lot about our PDMP already today, but now we get to talk about some of the success stories. And this is going to be presented by Amy Reynoldson, the Prescription Drug Overdose Prevention Coordinator from the Department of Health and Human Services, and Kevin Borcher, PharmD and PDMP Program Director with NeHII.
Hello, everyone. I do want to thank NeHII for allowing us the opportunity to be part of this great annual meeting. It's a great event, and really kind of toot our horn a little bit on what we've done with the PDMP. I wasn't sure where you went. So we work really quite frequently with each other. We're on the phone, daily, email. So we've got a great team, I think, between DHHS and NeHII, and it's been fun to look back at what we've accomplished. These are not my slides. There we go. Sorry about that. As you guys know, the headlines are frequent. They're daily, multiple times a day. You almost can't walk by a news channel and not hear something about the opioid crisis. These are just a few snippets of what's been going on a national level as well as a state level. And many of you know that we had an opioid summit last year in the fall up at UNMC, and it was a great success, and we're going to continue those endeavors. Nebraska is working hard to implement evidence-based prevention efforts to prevent this epidemic from coming into the state of Nebraska, as it has in so many states. Here are some more headlines from a national as well as local news sources. The opioid epidemic is consuming a variety of resources, and many still believe that on a national level we haven't even touched the iceberg yet. On a local level, we've established a comprehensive plan to address current issues in Nebraska. The plan includes a multifaceted approach focusing on improving prescribing behaviors and practices, enhancing the PDMP to assist users in providing the best care to all patients, increasing treatment services and providers in collaboration with the Division of Behavioral Health, and educating professionals and the public on naloxone, which includes accessing it and how to utilize it if necessary. In 2016, LB 471 was passed. This legislation brought a lot of new enhancements to our PDMP. As you can see, there's a lot listed there. I'm going to speak specifically to what the bill does require. The bill requires that all dispensers report all dispensed controlled substances beginning January 1st of 2017. That's primarily your community-based pharmacies, chain pharmacies have to upload the data on a daily basis as mandated by the statute to our PDMP program. Beginning January 1st of 2018, dispensers are mandated to report all dispensed prescription medication on a daily basis, and that starts January 1st. The legislation also prevents patients from opting out of their data being placed into the PDMP system. The PDMP is a free resource for dispensers and designees, individuals to access the PDMP on their behalf when being directly supervised. Now that was legislation in 2016, LB 471. It also established the Veterinarian Prescription Monitoring Task Force. Also in LB 471, they outlined the purpose of Nebraska's prescription drug monitoring program. The purpose is in place to prevent the misuse of controlled substances that are prescribed. It allows providers to monitor the care of all patients, including their treatment, and ensure that the prescription drugs are used for medically appropriate purposes. And then the PDMP is also provides Nebraska an opportunity to stay on the cutting edge of technology. As you've heard referenced earlier with the NeHII, we will be the first state in the United States to have our prescription drug monitoring program information merged with the NeHII. Bringing you to recent legislation, in May of this year, LB 223 passed. This legislation allows for prescribers and dispensers to designate a licensed or registered healthcare professional credentialed under the Uniform Credentialing Act to access the PDMP system on their behalf. This legislation also includes the mandatory training for prescription drug monitoring for all users prior to gaining access to the system. So if individuals want to gain access to the system on a voluntary basis, they must complete a training that's already been developed. You can do it in person, online, through on-demand, but you must complete that training and complete the documentation appropriately for us to give you access to the system. LB 223 also outlines that veterinarians will be required to report all dispensed controlled substances to the prescription drug monitoring program beginning July 1st of 2018. A few additional items that were included in this bill include the privacy and security protections as outlined by HIPAA and the protection of patient identifying data, that it will not be released, disclosed, or made public except to the statewide health information exchange. As you can see, NeHII is connected to a lot of funding sources. I can only speak to two of these. So to do it justice, I'm not sure if in the future you want to address your other two funding sources, but specifically I can speak to the Center for Disease Control and the Bureau of Justice funding. DHHS was awarded both of those grants in the fall of 2015 and aligned very quickly with NeHII as a collaborative partner. DHHS oversees the implementation of both grants, in which NeHII is helping put on the ground to put everything into practice. The CDC grants fund the PDMP enhancements, a pain guidance document that's in the process of being developed, and education on expanded access to naloxone. The Department of Justice grant focuses on PDMP software enhancements as well as the PDMP training efforts. So all of the mandatory training opportunities that are out there, that's funded through the DOJ grant. This endeavor of charting new waters would not be possible if we did not have all of our collaborative partners. The Nebraska PDMP effort has been made possible because of all of our stakeholders and partnerships that are at the table, are continuously answering questions and providing guidance on a very frequent basis. Those partners include physicians, pharmacists, the Nebraska Medical Association, Hospital Association, Pharmacists Association, and all of our professional boards, as well as our vendor, our PDMP host vendor, Dr. First. The stakeholders are called upon at various times and asked to provide feedback in a really quick turnaround time frame so we can keep our efforts moving forward. Their guidance, input, and ability to help navigate these waters have helped us to achieve many successes, and it's quite commendable. I'm now going to turn it over to Kevin, and he's going to go into detail on the PDMP program.
Thanks, Amy. So Amy has talked to us about where we've been, how we got there. I want to talk about where we are and where we're going. The slide that is up here now is of June 30th. Yesterday, we got updated numbers. Just to let you know, as of July 31st, we've had 1,820,437 prescription records put into the PDMP. A little less than 2 million as of July 31st. And remember, we've only been up for about 7 months. That's also looking at 498,000 patients who have had a controlled substance in that same time period. Now, I want to clarify what that means for a patient as we identify it. It's anyone with a specific address or zip code. So if Kevin Borcher had an address with a zip code of 68127 and 68137, I'd be 2 patients. So those numbers are a little falsely elevated, but you can still see the magnitude of this. We also have about 5,200 users, prescribers, and dispensers or pharmacists in the system right now available to access the system. So in a very short period of time, we've really come a long way. We've had a lot of promotional events that we've been asked to speak to, both local and regional, and just recently, 4 different national events that we've been asked to speak to about the PDMP. We're trying to leverage Optum and the interfaces and the infrastructure that they've had to integrate the PDMP, and we talked earlier about interoperability and integration, and this was a great opportunity. NeHII has been the first in the country to integrate the PDMP within an NeHII, and once again, we used both Optum and Dr. First to be able to accomplish this. And not only do we have the PDMP, but that med query functionality directly within the HIE. For those of you who have used the PDMP and the HIE, these screens are going to be familiar to you. I'm going to show them just briefly, but there are going to be big changes coming up in about 4 or 5 weeks here. You have 2 tiles or buttons. If you click on the PDMP button, you'll go into only PDMP data. If you're an HIE participant, you can click on the HIE button, and then you'll have the ability to click on the med query button. This is what the med query functionality button is going to look like. It's not been released yet, but it should be in the very near future, where you just need to click that, and it's going to pull up the PDMP data. This is an example of a typical screen that you'll see currently. Currently, if you're using the system, you need to put in 5 pieces of information, and for anyone who is a provider, you know that patients are giving different pieces of information to you, so that may not always work. So we're having some enhancements that I'm going to talk about here really quickly. The online access form is going to be available. This is going to be a quicker, easier, and better way if you've not signed up for the PDMP to be able to do that. Should be released later in August here. We also have some enhancements coming for the pharmacists in the room that are having to submit the data. There's going to be an enhanced error reporting system. Some prescriptions that get sent don't always make it in for a variety of reasons, missing date of birth, which is a required field, different pieces of information like that. We're working on an enhancement to make that easier and better for the pharmacy so we can have a more complete medical record there for those medications. We're also having some reports being able to be generated from us now as well. And that's going to give us ability for auditing tools and to provide you more updated numbers as to the number of prescriptions we're seeing at any particular time. We have some other prioritized enhancements based on a DHHS Drug Safety Advisory Group. These are some of the enhancements that we're going to be looking at coming up here very shortly. I talked about the enhanced patient search where you're not going to need anything more than patient name, zip code, and you're going to be able to have a much more robust selection to combine different quote-unquote patients to be able to pull them into the same person. Very similar to the MPI or Master Patient Index within the NeHII, but a little bit different method to do that. We're also having some clinical enhancements geared towards safety going to be in here. We're going to have a 556 rule, and this allows the users, the prescribers or dispensers, to see when they pull up a patient's profile, any patient who had received 5 or more prescriptions from the prescribers for opioids and 5 or more pharmacies in a 6-month period of time. You might think, well, that seems like an awful lot. I can tell you, once we get this, it happens, and it happens a lot. So this is going to be a very good enhancement that the prescribers are going to be able to see. We're also implementing an enhancement with the CDC suggestions of, they call it high-risk patients, where if you're on concomitantly benzodiazepines such as Ativan, Xanax, Valium, and an opioid, it's going to provide an alert for the user to see right face up. All these are scheduled to be later this year. This is something that you've heard a couple of times, and I really want to focus on this. Beginning January 1st of 2018, all prescriptions are going to be recorded to the PDMP. This is going to provide a very comprehensive medication history that no one in the country is going to match what Nebraska has. We're focusing on as a patient safety tool to really be able to help the providers have more information than they ever had before. You've heard about medication reconciliation. Dr. Rucker mentioned it, Dr. Zaruba mentioned it. Currently, what is MedRec? MedRec is really spelled W-R-E-C-K, right? I said that last year, I remember. It's still applicable this year. We're going to be changing that. MedRec is simply having a very complete medication history for that tool to know what the patient's on. You know how difficult it is to get that. You have the caregivers, the patients who are bad historians. You're lucky to get any information. Dr. Wescott was mentioning today at Good Sam where patients would bring in their garbage bags full of medications and you're after going through that. We've seen some of that before. It's time consuming, it's not very accurate, it's not safe to do that. You can review it within your EHR, not bad, but you're still missing information. There are different tools out there that might have 60 to 80% of a medication history now. Still not good enough, and it takes time. What we're going to have is a much better medication history tool where instead of having to ask the patient, okay, what medications are you on? And you're going through a very extensive list. You're going to be able to have this list already there. It's going to be very comprehensive. It's going to be very up to date. The data is sent on a daily basis. And then you can just say to the patient, I have this list. How accurate is this? If you're used to MedRec, you know that time-consuming piece is going to really be saved by doing this. So we're really excited about this. We've had a lot of eyes on this throughout the country. On the slide, with adverse drug events, you've seen the issues with that. With CMS and the hospital readmission reporting program or reduction program, we've seen higher rates of penalties this year than ever before. Some of those could be due to medications. And this is going to give you that better history there. Studies have demonstrated MedRec is beneficial, it is important. Verifying that list is something we need to do, and if we have a good list to start with, it makes the MedRec process better and easier all the way around. This is the testimonial that we always like to put in testimonials from the users themselves, and we don't modify the text. So this is coming from one of the pharmacists at one of our own. The PDMP is a great tool to use as a double check for patient safety. Great strides have been made in a short period of time to make it useful and more user-friendly. I look forward to seeing it expand into complete fill history along with the other monitoring features to serve Nebraska patients and healthcare providers. With that, we just wanted to thank everyone who's helped with this, with the Optum team, the NeHII team, and the Dr. First team. And there are several members that have all been listed here that have been making this very helpful. With that, we only have a couple of minutes for any questions. All right. Thank you very much.
I love the med rec. I got that a lot as I was doing that. I just want to give you a heads up. As you enter the golden years, you may find yourself having to be a patient. And I didn't particularly like that, but in my short time now, I've had to do that twice. And they were both, one was planned, one wasn't, but they were both health systems I had not been in before. And so I'm at the registration desk, and it was kind of cute. They both asked the same question. They said, "Have you ever heard of NeHII?" And I couldn't help myself. I just had to wait and see what they would say. And it's amazing how well our health systems are helping us support NeHII. There was no hesitation. There was no bias against us like there was when we first started, and the information was accurate and complete. So thank you to all the health system representatives that are in the room today. Next, we're going to have a report from our technical committee, and we're going to have Jennifer Brockhouse, the technical committee chair, Rachel Hausman, our project manager with NeHII, and Cindy Johansson, the HIE service manager from UHIN.
Thank you. I am going to introduce all of our committee members, and those of you who are present, if you wouldn't mind standing so they can see who all we are. Jane Carruthers, Dr. Cliff Kohlglazer, Monty Hodge, Ron Claver, Susan Lorkebeck, Joe Presch, Donna Wise, Wendy Worthing, and Dr. Delaney Wyckoff. Thank you. And thanks to all of you who get up in the morning to help with our call. I'm just going to go, this is a list of some projects we've done, and I'm just going to highlight a few of them. First, as I talk about, is the Dr. First PDMP enhancement functionality implementation. This has been a huge piece that has helped all of our clients, and we're with the state going to requiring all drugs in 2018. We see how that will be very helpful. We also review the Optum incident reports review, and we've only had a few of those, but we look at strategies on how to avoid those in the future. We also approved all of the implementation projects, and we had 35 of those in the last year, which is very huge. And then the last piece I have is that we did spend a lot of time on our platform migration from 1.0 to the 2.0 platform. And I am going to let Rachel discuss that changes for us.
Thanks, Jen. Certainly we cannot underestimate the essential role of the technical committee. As Jen mentioned, the 35 projects that were reviewed this year give you an idea of just the quantity of information that is being reviewed by the technical committee and the guidance that NeHII gets from that committee as those are being reviewed and assessed. So certainly we would be remiss if we did not talk about the platform migration during the last year. It was certainly the most dominant activity in a year full of hundreds of activities. within the platform migration, as we've given some of the facts related to PDMP, Kevin gives you an indication of the amount of data that was collected in that 7-month period. Well, when we look at what was collected for NeHII, and we have over 150 million different records that were collected since the HIE went live in 2009, and we were tasked with the challenge of migrating that information into the new system. We did evaluate and determine that we were only going to go back to the beginning of 2013. Even so, we needed to ensure that all of that information continued to be accurate and was presented in such a way in the new system where it continued to be of use to all of our users. So just a quick run through of the number of tasks that were involved with this, including ensuring functional parity between our existing system and the new system, in addition to the advances and the capabilities that were made available in the new system. The provisioning of all of our users from the old system to the new system, and the training that was required in order to show them how to use it and how to continue to gain value from it. And continuing all of the auditing, and while we were in the transition period, being able to use both systems at the same time and being able to audit who was using each system and still being able to maintain the privacy that's required. And then, of course, resulting in the shutdown of the 1.5 platform. We also really depend on the technical committee for assistance in determining what our future functionalities are going to be for the different funding streams that we have. For the 2016-2017, during the federal fiscal year 2017 IAPD, we had a number of different functionalities that we used the guidance from the technical committee to be able to help us understand what we should pursue, including the redesign of the immunization gateway, the beginning of the electronic lab reporting, the expanded syndromic surveillance, again working with the Division of Public Health and Dr. Safranek, the continued hospital and provider adoption activities, as well as some supplemental support for the PDMP. We also have worked with our technical committee for guidance for what projects to include in the current IAPD application that is under review with CMS, and that includes continuing a lot of those efforts that are underway in 2017 for federal fiscal year 2018 and beyond. In addition to the addition of allergies and diagnoses to our ADT information, the statewide ADT alerting is also a project that we've added to the proposal for 2018, which continues to encourage the adoption of NeHII by hospitals throughout the state in order to use those messages that describe the encounter events that are occurring statewide to be able to provide that information to all of the hospitals and clinics throughout the state, in addition to long-term care, as the use case was described earlier, so that the providers who are working with those patients are aware of the encounters that are happening outside of those health systems. We also depend on our technical committee for the determination of the projects and functionalities that are pursued through the state appropriation funding. And you can see on the list here a number of those, including the health exchange connectivity, which is something that we have a current project underway, starting our smoke testing and becoming a member of this nationwide network that helps facilitate the exchange of information and continues to broaden the data that's available to the users of NeHII. Also have a number of other efforts pertaining to the community care plan with WellCare and the activities that you can see here. We certainly cannot talk about the events of the past year without talking about our ONC Advanced Interoperability Grant. As we've spoken about the records and the number of users that we've brought on, the number of hospitals that have begun sharing their data, a lot of this is due to the funding support with the state of Nebraska being awarded this interoperability grant that was only awarded to 12 states. This was awarded in July of 2015, and it had a specific focus on critical access hospitals, long-term care, and public health and researchers. We had 3 major milestones that we were working towards: adoption, exchange, and interoperability. Under adoption, essentially is providing the tools. Exchange is actually using those tools to have the data flow, and interoperability is actually providing that data that's flowing and making it usable for the person that's on the other end. There was a requirement of this funding that for every $3 that we were receiving from the ONC, we had to provide $1 from NeHII. So certainly the considerable amount of funding that was available, but also a commitment that had to be provided from NeHII as well. So as we talk about the contents of this grant, we did have a number of partners. Again, the grant was awarded to the state of Nebraska and administered through the NITC. NeHII had a huge effort as part of this, but also we partnered with the University of Nebraska Medical Center, with Dr. Cochran and Marshall Marine and Dr. McClay and the other members of the team for the grant. As we have listed here the adoption projects, but essentially this was making sure that there were connections available and making sure that we had different opportunities to be able to provide this connectedness that met our participants at the stage that they were at. If they were only capable of using direct messages, that's what we were able to provide. If they were a clinic who had the capability to send a CCDA, then that's how we were able to connect. If they were a hospital or health system that was able to provide HL7 messages, that was the method that was used. For the exchange projects, you already heard a great deal about our integrated community effort, and that was certainly the project that really brought all of the pieces of this grant together, as you heard earlier from the members of that community. We also had the opportunity to be able to connect with other HIEs, and there's certainly, while healthcare is predominantly local, it's been very illuminating for us to be able to see when connecting through other HIEs, and as Cody's going to describe to us a few minutes, the patient-centered data home, how many messages actually do go back and forth and how much care is being provided across state lines or across regions. And so with the ONC grant, we were also able to connect to the Missouri Health Connection, which was one of the HIE to HIE Gateway projects that was accomplished, and we're also in the progress right now of connecting to Unity Point Health, which represents a number of hospitals in the state of Iowa. For our interoperability projects, we were able to continue to provide syndromic surveillance reporting through NeHII, through the same connections that were already made as data sharing partners. We also were able to bring on a population health analytics tool. This is Optum's Spectrum platform, which was designed for HIEs, and it has we have 6 different pilot facilities that now have users provisioned that are able to use this population health tool to better understand their patients and some of the nuances of the population, rather than looking at the individual data for each patient that had been available in the HIE. We also worked with, as I mentioned, Dr. McClay and Dr. Campbell to be able to provide information that can be used as part of the CoreNet, which is part of the Patient-Centered Outcome Research Institute that continues to broaden the information that's available for researchers as they're doing studies based on de-identified data to determine the efficacy of various treatment plans. So that was a project that is still in stages of completion, but one that has the potential to have a large impact. In addition, we have partnered with the College of Pharmacy to be able to really do a proof of concept to show some of the information that can be queried, it can be returned on a de-identified basis to be able to answer some of the questions that are being posed by the researchers at the University of Nebraska Medical Center. So I will now turn it over to Cody, who is going to talk about another project that NeHII was able to complete during the past year that is pertaining to connectivity to other HIEs and the exchange of information. Cody.
Alrighty, so I guess I have to start out with, I've been called a lot of different names in my life. It's kind of confusing to get Corey and Toby and all that, but I guess I've never been called Cindy, so that's the first Dr. Wescott. So I'll take it as a compliment because, it's good to be part of the fairer sex, I guess. So anyway, the project that we've been able to do, though, I'm from UHIN. We're the statewide HIA that services Utah, the state of Utah. It's great to be out here in Nebraska. This is my first time, and it's been wonderful. You guys have great steaks and great food. So, but what we've been doing with NeHII is we've been working on something that's been sponsored by SHEIC, the Strategic HIE Collaborative, and it's something called the Patient-Centered Data Home, or PCDH. And the concept behind it is really simple, that wherever a patient goes, their information should be able to follow them. And patients don't necessarily stay to geopolitical boundaries. They go outside of their states, they go to other HIEs, to other service areas. So the whole concept is that they're going to move, and their information should move with them. So this is a nice little diagram, and it's got a lot of words, but to give it a real simple example, there's a home HIE and a visiting HIE. So let's use an example. Let's say there's someone named Cody Johansson, because that's easy for me to remember. He's visiting Nebraska. His home is in Utah, so his home HIE is UHIN, and his visiting HIE is NeHII. Let's say while he's visiting Nebraska, something unfortunate happens, he has to go to a hospital. He has a visit at the hospital. The hospital, they do their thing, and an ADT is created at the hospital. That gets to NeHII. Well, NeHII has built in now to it to be able to route that based off of the zip code of the patient's home address to Utah. And then Utah is able to get that address or get that ADT, see that that patient had a visit in Nebraska, and notify anybody that's subscribed to receive an alert on that patient, as well as to include information in the Utah HIE to know that there's information in the Nebraska HIE. So it's really connecting HIEs among different organizations. And what's valuable about this as well is that then also NeHII is able to know that, hey, Cody is a patient from another HIE. He might have background information from that other HIE. Let's see if we need to get any information from him or not. So that's really the gist behind the whole PCDH, Patient-Centered Data Home, and how it works and what it does. Some, nice points of the solution is that it's really built into the current workflows and current alerting systems, because it really uses your current alerting system. It also is scalable. We're actually building it out now to connect the different regions. So UHIN is connected with multiple HIEs, including the HIEs in Nevada, Idaho, Western Colorado, Arizona, and Santa Cruz and San Diego in California. And then there are other PCDH projects. There's a Heartland project that has a lot of the Midwest, actually, of Indiana and Michigan and that area. And then there's a central project, Central Plains, that's Oklahoma, Arkansas area. And we're connecting all of these PCDH projects so that we'll be able to, shortly in the coming weeks, be able to exchange information among all of these different HIEs quickly and easily. So it's very scalable and able to be used at different areas. One of the biggest parts of it is that the patient's information is able to follow them, and it's included in the HIE in their longitudinal record. So how useful is this, though? You probably think a lot like, well, Nebraska, how many people actually go to Utah or go to Arizona from Nebraska? So we actually ran a few numbers. We've been live with Nebraska since July 6th, and we ran numbers from July 6th to the 24th. So just really quick to point out that we have a number of 24 ADTs usually sent from Nebraska to UHIN every single day, and there have been 105 patients for which that has happened over that period. It's an 18-day period, so I actually did that. It's actually about 5.8 patients a day. So there's 5.8 patients a day that are seen in Nebraska that have home addresses outside of Nebraska. So it's really interesting. You wouldn't think that you'd have that much overlap, but just wanted to share that with you, and it's a really exciting project that we've all been working on, and it's really going to be able to really connect all the HIEs across the nation and be able to get all that information together. And I'll turn it back over to Dr. Wescott.
Thank you, Cindy. I'll tell you what, I'm just a week out from my cataract. They told me to take a month for my vision to stabilize, so I don't think it was really my fault. So, okay, we're going to take a 15-minute break, and in case you can't remember where you're at, Deb and her staff have conveniently put the NeHII logo on the cookies. So enjoy your break, and we'll see you back in about 15 minutes.